Good afternoon, everyone. This is Dr. Sheetal from Nethradhama Eye Hospital.
Not all of them. We can
And
fix
we are
it like
going to
that.
relay some cataract and refractive
To
surgeries
just
from our
talk,
center.
the big point of this,
And I'm going to demonstrate a case of RELEX
that we
smile
can
procedure.
bring it in its
My
clever and
patient
master
is a
procedure.
23-year-old male. His
And I
corrected
tried
vision
it
is
also
20/20 in
with the
both the
donor
eyes. His right eye has a
polyimide
refraction
or
of -2
polyvinyl
diopters,
and a proline
and the
haptics.
left eye is
But in the
-1.25.
beginning phase,
His
when
angle
you're not
kappa
so
is normal
skillful,
in both the
sometimes
eyes.
you kink
And if you look
a
at his
little bit,
topography,
the
topography
haptic,
also
and you
is
won't
normal.
get it out.
All the
And so
quad
you have
maps
a
are normal,
decentration. And therefore,
and the Bellin-Ambrosio
we look for
enhanced
the
ectasia
another
screening
lens,
map is
and
also
there
normal.
is only one lens on the
So
market which
I'm
has
going to
the
start the procedure, but before I start the procedure, I want to show you the parameters of the surgery which I'm going to use. So I'll be using a cap thickness of
and this
120
haptic you
microns,
cannot kink.
a lenticule,
And it's beautiful.
the optical
And
zone of
I would
6.7
really
millimeters.
recommend
So I'm
for
using a
everybody
slightly
when
large
he starts
optical
with this
zone because
technique,
it's a thin lenticule.
you can try it
So
with
increasing
proline,
the optical
but
zone
if you
increases
don't
the
want to
thickness
make
of the lenticule as well.
the problems
And
we
I'm
all have
also
with the
increasing
proline,
the
then
peripheral
I would
thickness of the
recommend
lenticule
just
to
to
30 microns.
switch to these
So the residual bed thickness of this patient's right eye is 377
fluoride
microns,
haptic,
which
because you
is a
cannot
very good
kink it.
RST.
Even if you crack it like
So
this,
we're going
it
to
comes always to the same
start
design.
the procedure
And
now.
so it's very
Next.
helpful. And you can
I'm going
use
to attach
the
the cone.
30 gauge needle.
So
It's
it's very
called 30
important
gauge thin
when we are
wall
attaching
needle.
the cone,
And if you cannot have
we
access,
should not touch
like
the
they have in
undersurface of
Egypt,
the
then
contact
you can
glass.
take also
Because
the
if you touch the
27 gauge needle.
undersurface, you can
Actually, this is
have
was a
stains
28 gauge.
Or 28 gauge,
Yes, it's,
yeah.
or
because I want the
fingerprints
scleral track as
under the
tight
contact
as
glass,
possible
which can affect the
in
laser
order
delivery.
not to allow slippage. of the-
Guys, I'm sorry, I don't want to cut across you,
So
but
now I'm going to
we've got to
prepare
go
the
to India
patient's
now.
eye.
We've got the feed. Now, we haven't got sound, so
please,
we're going to have
blink
to try and
nicely.
commentate on this. The first case is
Open
a
your eyes.
RELEX smile.
Look up fully.
And this is in a 23-year-old male patient who is a low myope, -2 in one eye, -1.25 in the other, with good visual potential.
So I like to relax, please. Please relax. Please relax. We're just
So
putting
then
a
I'm
small
readying the patient.
clip in your eye. Relax, please.
I wonder
Open both
if a
the
smile
eyes.
is recommended for
please.
low myope in
Yes,
Europe.
but it's very low. It's
Look
very
very
low.
low.
myopia.
Oh,
they
yes.
they increase optical zone to increase the thickness of the
Look straight, please.
lenticle.
Please look
Maybe,
straight.
but
Look straight.
I am not able to see
Look
what was the thickness of the lenticle into the video.
The thickness of the lenticule is 70 microns, 70.
No, that's all the pentagram stuff.
Am I audible? Look straight into the light. So now we are going to dock the eye.
Quest'anno è il primo anno che facciamo tutto in streaming, gli anni scorsi abbiamo sempre usato il satellite. Direi che le immagini sono state ottime in questi giorni e anche le connessioni, diciamo, in generale. Qualche problema c'è stato con la voce, come in questo caso. La qualità
So patient has already been explained about the green light.
L'evoluzione, secondo me,
And
deve andare
as we
verso
approach the
streaming.
cornea towards the
Il
contact
satellite
glass,
senz'altro è una
we ask the patient to look into the
modalità
green
molto
light.
buona e molto ben collaudata, però ormai con la
Microscope
funzione
view,
di
please.
computer,
Please give the
eccetera,
microscope view.
certamente bisogna aggiustare un po' la tecnologia, aggiustare
Microscope view.
determinate cose, perché ci sono purtroppo diversi
So,
nodi che devono passare
you ask the
indenniti
patient to
prima
look into
che
the green
l'immagine
light,
arrivi buona.
and
Non
as the
solo
cornea
questa
touches the contact
cosa,
glass,
l'immagine di
you see this
partenza,
tear
lo so, deve andare
meniscus.
su internet, anche lì ci sono, specialmente nelle connessioni internazionali,
This
diversi
tear meniscus
passaggi,
should be
che deve arrivare qui in
uniform.
hotel, anche qui deve trovare le giuste connessioni.
Look
Insomma,
into the
non è
light, please.
così semplice come potrebbe
Yeah, light
sembrare
में देखिए.
a prima vista. Quindi
Look
io
slightly
sono molto
down.
soddisfatto finora come è venuto il meeting, non è tutto perfetto, ci sarà ancora spazio.
Okay, the green light should be in the center of the pupil.
Vediamo adesso le immagini dall'India.
And now we are good to go with the laser.
Immagini molto buone,
Laser शुरू हो चुका है. Just relax, please. Don't move. Don't move. Relax. Very good. The light may disappear. Don't search for it. Don't talk, please. Relax.
Il videocataratta è innovativo,
Relax.
dobbiamo innovare anche in
So
questo.
that's the cap being formed.
In this case, we will have a very big lenticle because the
And I'm
thickness
using a
is-
3 millimeter
is
superior
very- is
incision.
very thin. And difficulties in this case is to engage the lenticle because the space between the external zone of the smile, the cap of the smile, and the lenticle is very small. And it's very difficult to catch the planes, the right planes,
they're able to
up
see.
and down planes.
Look straight
Due
into
to
the light, please.
to the thickness of the lenticle. But now we are waiting to see the video.
Look straight into
to
the light.
understand what will be the thickness
Look down slightly. Yes.
of this lenticle.
Keep your eye like
Do
this.
not ask to the surgeon
It's okay.
information.
So
because
I
we
massage
don't
the
have
center of the cornea
audio
to improve the visibility for the patient.
between the surgeon
And I'm using the
and
Reinstein
here
dissector.
we are trying to
So with the Sinski side,
to have the
I
connection,
make 2 pockets.
the audio connection.
I make the superficial pocket on the left
But
side,
anyway, we have here the cornea
And then
mark of the patient.
the deep
and,
pocket
we
on the
have,
right side,
570 microns in the center
and
of the cornea.
then I flip over
The
and with
refraction
the
was,
blunt dissector,
will be -2.
I enter
and
into the
right
superficial
eye,
plane
She is approaching the right side, I think.
and I'm dissecting the superficial plane right now. It's very important to dissect the plane completely and also the sides.
If you have some question, you have no. Oh, we will try to.
Okay.
No,
Well,
Now
can I
I'm
ask you,
going
Sri
into
Ganesh,
the deeper
this
plane.
young man it's not a high myope, but do you think this is the best procedure, or would you think that laser called PRK would be a better procedure?
I
And
think
while
that
dissecting the
is
deeper
best
plane,
procedure.
when
I'm
you
doing
dissect the lower
always
4
a
clock
smile,
hours, when
starting
you
from
see the lenticle
1.75
being separated, it's a good sign.
till 8-9 diopter
And
when
then
it is possible.
I also like to
Because I think that
keep 2
it's the
hinges
best refractive
on both the sides.
surgery procedure.
These are 2 tissue anchors which give counter traction and prevent the lenticule from rolling over. So once the lenticule is separated, you can actually go on top of the lenticule and take it out. If it's not coming out easily, then you can use a forceps to remove the lenticule. Some saline on the cornea, please. Look straight into the light, please. So I have already separated the lenticule, but I just need to remove it. Look slightly down. Give me forceps, please. It's good to fixate the eye so that the cap doesn't tear when your instrument is inside the pocket. So the lenticle is already separated. I'm just going to extract it out of the pocket now. It's a thin lenticule, so we have to be very careful. It's a good idea not to pull the lenticule, but just hold it and remove it like a Rex's. Okay, there's a slight attachment there. Now the lenticle is free and it's extracted. We are going to check the lenticule now. It's a good practice to check the integrity of the lenticule and see whether the margins are round and if there is any loss of tissue. So the lenticule is complete and that's pretty much the end of the surgery. In the end, I would like to also massage the cornea. Look straight into the light, please. Massage the cornea. So this is cap ironing. So doing the cap ironing helps in first day visual recovery. It improves the recovery on the first day as it lessens the Bowman's membrane distortions, which are known to occur after smile surgery, and they can interfere in the vision. So the final step is checking the interface and the side cut using the inbuilt slit lamp in the Visumex laser. So everything looks good. And that's the end of the procedure. Do we have any questions? Do we have any questions from the panel or the audience? Okay, so if there are no further questions, I would like to shift the transmission to our cataract OR, where Dr. Sri Ganesh is ready with his patient. Thank you so much for joining, and thanks a lot for this wonderful opportunity. Thank you.
Good afternoon.
Yes, I'm asking
This
about
is Dr.
the
Sheetal.
Welcome to Nethradhama Hospitals Private Limited, our cataract OR, where we will be demonstrating a few cases. I'm the chairman and managing director and the main cataract and refractive surgeon. So the first case we will be demonstrating a case of Toric ICL. This is a 46-year-old female and we are operating on the left eye, and the refraction is -11 with 1.5. The ACD is 2.77, and I'll be showing my technique. We will have to rotate the lens and 4 degrees clockwise after implantation. And we will be operating on the RTO 800, which is the first digital 3D microscope. And I'm wearing the 3D glasses, and I'll be looking at the screen when I operate. So first we will have loading of the ICL. Microscope view, yeah. So this is just put in a little bit of BSS and HPMC. This is the Toric ICL in the bottle. You will have to insert the flange. And then I use a pull-through forceps. So you go in, hold the lens, and pull through. Then I load it into the injector, and the lens is ready for injection. I put it into the bottle of BSS, and we shift the patient now. This is the left eye, and I am sitting temporarily. So I have the trolley coming in so that I don't have to change the microscope or the screen. For the left eye, the trolley comes in from the left, and for the right eye, the trolley comes in from the right. Light kanatama, light and okay, now we are going to use the Callisto overlay. We have to rotate the lens 4 degrees clockwise, so I am going to set it at 176 degrees. I use a single incision, 2.8 mm incision, temporarily, so that is the 2.8 mm incision. Then I use sodium hyaluronate. Before that, I just inject 1% xylocaine, preservative free, and that is the sodium hyaluronate being injected to form the chamber. I do not make any side ports. I have a special instrument which I have made, the Ganesh ICL manipulator, which is actually a cannula, which is sandblasted on the undersurface. So this is the cannula, which has a curvature. So it can be used to inject viscoelastic also. that is the insertion of the leading haptics, and then the trailing haptic is inserted under the iris. And then we position the ICL as per the Callisto overlay, the Z align. Enter with my irrigation aspiration cannula. I gently rock it so that if it is entrapped in the zonules, it gets released. I use a high flow rate, 60 flow, and you can see that the helon is evacuated as a bolus. Light Nodima. Light and I'm adjusting the pressure, intraocular pressure. And I'm going to check the vault now with the OCT.
Allora, mute. No, cosa ancora questo qua?
I'm using the OCT. Guarda image. OCT image.
No video.
OCT image is not.
Allora, digli che siamo entrati in Zoom, così ci vede. Siamo entrati in Zoom, noi vediamo il loro video. È un jack 3 mezzi.
So you can see the lens is aligned.
Adesso forse stiamo mettendo l'audio di ritorno.
OCT, no.
So you see that we are connected, and now we are checking the audio. You have questions?
Forget it. So that's the end of the procedure. With the online OCT, you can check the vault, but we're not getting the image right now. So we'll move on to the other case.
Non lo so.
Okay. So this was the ICL, Toric ICL with the Callisto. The next case, again, I'll be operating is a 65-year-old female with a near mature cataract. It's a grade 4 cataract. Vision is counting fingers 3 meters. It's a very dense cataract, so I'm going to use the miLoop. The miLoop is a new device, which is a nitinol filament, which is used to cut the cataract, and it can cut the densest cataracts, and it reduces the total phaco energy. And we are implanting 21.5 adapters, CT LUCIA. I'm using the Centurion phaco machine from Alcon. The flow rate is 60 flow rate and 700 vacuum. Show the screen.
Not the still voice.
The resistor is in the mood. It's not in.
And we are implanting a 21.5 adapter I'm using the Centurion phaco machine from Alcon. The flow rate is 60 flow rate and 700 vacuum.
As you have seen, Dr. Ganesh has used the new ZEISS 3D system named Artevo, which is a really interesting and high quality system. So this is the reason he had some special glasses on his face. And the ICL he used had a central hole that allows any movement of the aqueous inside through the lens, the anterior surface of the lens and the posterior surface of the ICL. In this case, you do not need to produce any iridectomy to preserve any pupillary block, of course.
Ci sono circa 30 secondi di ritardo nella voce, quindi quando la domanda verrà fatta sarà in ritardo nella risposta.
So this is the dense cataract, mature cataract almost, light and non-turbid. So we are making the side port incision 1 millimeter.
Anyway, he used the Callisto before because it was not available on the screen because it's available only on the monitor.
And then we are staining the capsule with trypan blue.
Un po' compatto,
Rexis
contiene una serie di strumentazioni dentro.
Is a subluxated cataract?
So we wait for about 15 seconds and then wash out the stain.
And then we are staining the capsule with trypan blue. So it's just overlay.
So you can see this is the overlay from the Callisto, which is the Rexis marker, and it has two lines at 5 millimeters and 6 millimeters.
The images are excellent.
So we wait for about 15 seconds and then wash out the stain. So you can see this is the overlay from the Callisto, which is the Rexis marker, and it has two lines.
That is the Rexis being completed. And we have a 5.5 mm Rexis now. Then I go in with the hydro cannula, which is a 27 gauge cannula. And it is very important to do a good hydro dissection when you are using the miLoop. So you see the nucleus rising. You can't see the fluid wave because the cataract is dense. And you can easily rotate the nucleus.
Rexis technique.
Now I'm using this coat.
It's good for that case.
This is the miLoop device from ZEISS.
You can't see the fluid there because the cataract is dense, and you can easily rotate.
Put off the Rexis marker. Put off the Rexis marker.
So I'm using this coat.
So you go in through the main incision, open the loop, see that it goes under the anterior capsule, open it completely. Once you open it completely, then you rotate. See the black mark at the wound. You can see the posterior part of the nitinol filament going across the midline, and then bring it close, and then before you close the loop, you use a second instrument to support the posterior pole and prevent it from lifting. And then you can cut the cataract.
See the black mark at the wound. You can see the posterior part of the nitinol filament going across the midline.
Then you put in some more visco, you can see it is split into two. Light Nodima.
You use the second instrument to support the posterior pole and prevent it from lifting. And then you can cut the cataract.
Then you put in the miLoop again, open it completely, rotate it.
And you put in some more visco, you can see the split into two. Light Nodima.
and you are able to split the nucleus into now 4 fragments.
When you're putting the miLoop again, open it completely,
Light
rotate
item.
it.
So it reduces the phaco energy by almost 50%, and endothelial counts are much better post-op. So I go in with the phaco and then I'm emulsifying the, you can see it's quite easy to remove even the dense nucleus once it is cut into the fragments.
So it reduces the phaco energy by almost 50%, and endothelial counts are much better post-op.
You can chop it into smaller fragments. And you can see what that's the last fragment being removed. So even in this grade 4 cataract, it is, you can see that the viscoat is still there, protecting the endothelium. I am clearing the viscoat now.
You can chop it into smaller fragments.
You can see the CD now. How much is the CD? The CD is just 4.57 because I'm using a high flow rate, 60 flow rate, 700 vacuum, OZIL, and with the miLoop. With all this, you can reduce the total phaco energy so that the corneas are very clear on day 1. Now I'm going in with the IA. Okay, microscope view, please.
You can see the CD now. How much is the CD? The CD is just 4.57 because I'm using the high flow rate, 60 flow rate, 700 vacuum, OZIL, and with the miLoop. With all this, you can reduce the total phaco energy so that the corneas are very clear on day 1. Now I'm going in with the IA. Okay, microscope here, please.
I'm doing polish, hydropolish of the poster capsule so that any remnants of cortex.
To give a very large capsulotomy for this technique, or you can do with a smaller capsulotomy?
Average about 5.5. I like to use a capsulotomy of about 5.5, between 5 to 5.5. Here it is slightly larger, maybe like about 5.75. And I like to inject my lenses under saline, under BSS. So this is the CT LUCIA lens, which is the preloaded lens from ZEISS. And I'm injecting it into the capsular bag.
And I like to inject my lenses under saline.
You can see just a little bit of the viscoelastic is aspirated, and there is no visco in the capsular bag, so that makes the surgery faster, and the effective lens position also is stable because there is no viscoelastic. Light connector.
And there is no visco in the capsular bag.
So the next case which we will be demonstrating is a case of femto cataract laser surgery. So we have done the flanks with the catalyst system already, and she is a 69-year-old female, and the left eye, it is a grade 1 to 2 nucleus with post subcapsular cataract. I am using the Centurion machine. the RTO 800, and in this case we are going to implant a LISA toric, LISA tree toric lens, 22.5 diopter lens.
Without microscope.
And she is a 69-year-old female, and the left hand, it is a grade 1 to 2 nucleus with necessary cataract. I'm using the Centurion machine, the RTO 800, and in this case we are going to implant a LISA tree lens, 22.5
Okay, Callisto. Light ಏನು ನೋಡ್ತಾ ಕಣ್ಣಲ್ಲಿ ಆಡಿಸ್ಬಿಡಿ, 3 light ಇದೆ. Look at the 3 lights, please. Look at the 3 lights, don't move your eyes. Okay. Now we have to place the lens at 169 degrees. So I have put in the Callisto system and you can see that the axis at 169 degrees. So I make the side port and the main incision. I like to make a trapezoid incision, and I like to make the incision with blade. I go in through the side port. The AC is very shallow, so I am putting some viscoelastic. And I just press down on to get a free flap, then that's the hydrodissection, decompression of the nucleus.
The AC is very shallow, so I'm putting some viscoelastic.
And then I use viscoat, and I'm going to show you the technique of visco chop, where you inject visco into the substance of the nucleus at the nucleotomy, and it splits it.
Just press down to get a free flap, then there's a hydrodissection, decompression of the nucleus.
This is visco chop technique.
And then I use visco, and I'm going to show you the technique of visco chop, where you inject visco into the substance of the nucleus at the nucleotomy, and it splits it.
So this is a one-hand technique, because you have already have 4 quadrants. So it is very easy to remove the fragments. This is a 5.5 millimeter rexis with the femto. I like to make a larger rexis for the LISA lenses.
So it is very easy to remove the fragments.
This is removal of the cortical matter.
This is a 5.5 millimeter rexis with the femto. I like to make a larger rexis for the LISA lenses.
Light nodi. Look at the light, please. This is again polishing the poster capsule with BSS to remove any small cortical remnants. You can see the cortical remnants in the capsular bag coming out.
This is again polishing the poster capsule with BSS to remove any small cortical remnants. You can see the cortical remnants in the capsular bag coming
This is the trifocal. Light and I rotate it into position before inserting the haptics, the trailing haptics. The leading haptics are put into the capsular bag, and then once I put it in position, then I put the trailing haptics into the bag, and then it is very stable. You can kind of finely position it as per the Z align, and you can see that it is aligned well.
Rotate it into position before inserting the haptics, the trailing haptics. The leading haptics are put into the capsular bag, and then once I put it in position, then I put the trailing haptics into the bag, and then it is very stable. You can kind of finely position it as per the
Light connector. Light connector. Can you see the light? Okay. Fine. So that's the end of the procedure. And now we will go on to the next case. My colleague Dr. Savio will be doing the case. Oculars. So that was the demonstration of the ICL, my technique where I make a single incision. I don't make a side port, and I have my own ICL manipulator. The second case was a very dense cataract. It was a grade 4 mature cataract, where we use the miLoop to easily cut the nucleus into fragments. And then the third case was a femtocataract with the Lisa tree. So over to Dr. Savio. You can just start.
ICL manipulator. The second case.
Big shift ಮಾಡಿ. Itagiri, put this. Yeah. Dr. Savio will be using the oculars. So this is a hybrid system where you can use both the oculars and the 3D screen. The RTO, that's the advantage of the RTO system. Hello. Is there a question?
Or where can you control the axis of the toric lenses?
Yes, we have the information from the IOL Master 700. We transferred it via forum to the cloud, and then we have the EQ workstation, and it is transferred to the Callisto.
50 seconds back.
And from the Callisto, you can get the axis. So in this case also, Dr. Savio, my colleague, he's also a senior phaco surgeon.
Yes, there was a question about the control of the toric axis.
We have the information from the IOL Master 700. We transferred it via forum to the cloud, and then we have the EQ workstation, and it is transferred to the Callisto. And from the Callisto, you can get the axis. So in this case also, Dr. Savio, my colleague, is also a senior phaco surgeon.
So the second case,
Do you see the
case of a toric.
the lines of the Callisto in the In your glasses or on the screen?
No, you see it on the
Or
screen.
where do you see it?
You see it on the screen.
We couldn't follow it here.
Okay. So you see
Here we see it now.
axis marking on the screen. You can see it now.
Yeah, that's very, very nice. So you see it on the screen.
Yes. And it's even injected into the right ocular of the eyepiece.
What is your experience without using the binocular of the microscope?
I've been using the system from about nearly 2 months now, and now I don't like to use the oculars because the visualization is much better, and your depth of field is much better, and you have to use a very low illumination. You could say I was using an illumination of only 13%. So now I don't prefer to use the oculars. I just use the 3D glasses and use the screen and do all the surgeries, including the complex surgeries.
I've been using the system from about nearly 2 months now, and now I don't like to use the oculars because the visualization is much better, and your depth of field is much better, and you have to use a very low illumination. You could say I was using an illumination of only 13%. So now I don't prefer to use the oculars. I just use the 3D glasses and use the screen and do all the surgeries, including the complex surgeries.
Is the time lag between that, what you are doing during surgery, and what you see on the screen, is there a time lag, or is it really instantly projected on the screen?
With the RTO, it is instant because the lag is less than 20 milliseconds. And generally, if the lag is less than 50 milliseconds.
If you have a refractive error in one of your eyes, how do you correct that? Because on the microscope, you can just adjust the ocular.
I basically have a correction for my left eye because I have undergone Presbyon surgery. So my left eye is myopic by 1.7 diopters. So this is my glasses. The left eye is myopic and the right eye is plano. And then I have the polarizing glasses over the glasses which correct the refractive error.
I basically have a correction for my left eye because I have undergone Presbyon surgery. So my left eye is myopic by 1.7 diopters. So this is my glasses. The left eye is myopic and the right eye is plano. And then I have the polarizing glasses over the glasses which correct the refractive error.
Because I did the same, but I use a contact lens on my right eye to compensate the difference.
Yeah, you can wear a contact lens also, but I just wear glasses. It's quite comfortable.
Hello everyone, Dr. Savio Pereira.
You can proceed with the next case.
On the patient, 68-year-old female, the right eye, pre-op vision is 6 by 36, and she has a bit of cataract and 2 PSC, small PSC blah. And we're using this coat as my preferred viscoelastic and Centurion, and the toric lens and the implanting is 21.5 diopters plus 1.5 diopters of astigmatism. And this is the ZEISS TORBI lens. The axis of placement is 180 degrees. So I'll be starting off surgery. So what I usually do is make my side port incisions first. And then I like to prefer to make my rexis through my side port. And first putting the intracameral anesthesia of, like noted.
Toric, they take
the advantage of doing the rexis to the side port is that there's no leakage of viscoelastic. So go ahead. advantage of putting the viscoelastic and doing the RELEX to the side so there's no leak and you can finish your RELEX in one go. Then I'd like to make my axis incision at 180 light node.
I really love to see that you're doing the capsule rexis with the original needle technique.
Yeah, so that's the way we actually always learn rexis. And there you can see I have done the hydro, just tapping it down gently, doing this rotation, light node. So a few air bubbles come and sometimes just be a little careful, remove the air bubbles if they impair your visualization.
Yeah, so that's the way we actually always learn rexis. And there you can see I have done the hydro, just tapping it down gently, doing this rotation, like node.
So they just chop the lens into half, rotate it.
Impair your visualization.
What do you think about that?
Sometimes the cortical
So
matter
what I
just
see is
obscures your view.
you're using now the oculars of the same microscope.
Yes. So that's the beauty about this microscope, that you can go ahead and use both the Oculus and the 3D visualization system. So once you go ahead and chop, you can just pick up your pieces and you can chop it further.
Sometimes the cortical matter just obscures your view.
So separate the pieces, and the beauty about this tip is that you can just hold it sideways, and it does, because of the original FACO component, it just readily eats the pieces up so easily.
Pick up your pieces and chop it.
So sometimes the posterior plate doesn't crack. You can just go ahead and just separate it so that it becomes less turbulence in the FACO chamber while doing FACO in the anterior chamber. You can just remove out your other hand, and you can see once the pieces are chopped, they'll come readily because of the good fluidics.
And it does, because of the torsional FACO component, it just readily eats the pieces up so easily. So sometimes the posterior plate doesn't crack. You can just go ahead and just separate it. So that it becomes less of turbulence in the FACO chamber while in FACO.
I use the bimanual irrigation aspiration, more of preference. The advantage I feel with this is that in case it's a small pupil or something, it always acts as another additional hand. And you can go in areas, if there's a cortical piece, especially at the equator, it's easier to wash. More of preference. Though it takes time because you have to actually change hands. But overall, I feel it's a certain preference. It's much more faster when you do the coaxial. So we have the calestro on right now, and the axis of placement is 180 degrees.
More of preference. So it takes time because you have to actually change hands. But
so you can always, the preference is to put the leading haptics in the bag. The trailing haptics, you can leave it out. The good thing about that is that you can always adjust the position and do a fine tuning if you need. Now you can see the air bubbles and visco trapped behind. It's very important to remove all the visco when especially you're putting your toric lenses. And there, you can see the air bubbles are absolutely free. Now you can put in your trailing haptic. You can do a visco wash from the anterior part because you know its posterior is all washed.
the good thing about that is
You can re-verify the axis to do a fine tuning, and if required,
right? If you air bubbles and visco trapped behind,
So, just do a light wrist washer, re-verify your axis, tap on the lens, see if the axis is perfect. And then when the final check is always after you do your hydro, look for the overlap of the rexes. See if the axis is at the intended axis. In case you can always introduce your hydro cannula from the side port and just do a fine tuning of the axis, so in case that is required. So yeah, I always feel that it's always nice, once you remove the speculum also, you can just verify, and you can always just tap down on the lens if required. That's about it.
So those were the cases. Excellent surgery, Dr. Savio, and we were able to demonstrate about 5 cases.
Just do a fine tuning of the axis in case that is required. So, yeah.
Are there any questions about this case?
And you can always just tap down on the lens if required. That's perfect.
Very nice.
So those were the cases. Excellent surgery, Dr. Savio, and you were able to demonstrate about 5 cases.
Thank you very much, Sri. Very nice surgery, very nice.
Thank you.
Some little problem at the beginning with the voice connections, but the surgery was very good and the quality of image is superb.
Thank you, Professor Lucio, and thank you very much for this opportunity where we were able to relay cases with our techniques from India to video cataracta. Thank you again very much, and have a nice day.